Right. Good morning. Good morning to you who decided to join rather early in the morning after a rather late evening. We are going to have a session with 3 presentations around harm reduction. Harm reduction is a set of rules, of acts, programs and practices, but that's a lot more than that. And you're going to discover that thanks to 3 conferences. This session will start straight ahead and will last until 10:45 when we'll have a break. And we are going to entrust the moderation of this session to 2 very well-known people in harm reduction. Béatrice STAMBUL, she's a psychiatrist, member of Médecins du Monde for more than 30 years. She works in the PACA region. She's a mainstay in that field. She is well known for her projects for consumption injection rooms. She's a member of a number of associations, works a lot on mental health, precarity, access to healthcare for people with in a difficult situation, migrant as well, and she's the vice president of APHN. I probably forget many of their many hats, and I'm sure that you know Béatrice very well, so I'm not going to tell more. Patrick AEBERHARD is also to be a co-moderator, and I'm sure this will provide for a very rich discussion. Patrick AEBERHARD is a cardiologist. He has a PhD in law. He wrote a number of books, contributed to the creation of Médecins du Monde and Médecins Without Borders. He also conducted a number of humanitarian missions in Lebanon, Afghanistan, in the Biafra as well. I'm not going to cite all the countries where he went, operated, and did humanitarian missions. He's an important personality. He was an advisor for Bernard Kouchner, the health minister, and he was responsible for drafting a number of reports. He wrote many articles and papers, 230. I could cite the 230 papers. He would leave time for the people to join, and the interpreters would be dead by then. He also wrote a number of OPs, strategy of humanitarian intervention, and 2019 was his latest book, Harm Reduction in People Who Inject Drug, the Role of NGOs. Now, those were, in a nutshell, what I could say about those co-moderators. I'm going to give to hand it over to the speakers. We changed the order of speakers slightly. We're going to start by Sandra Kommer. She's going to talk about the different treatments in the opioid use disorders. She's going to talk about preclinical and clinical studies. Then we will have a reflection on how harm reduction contribute to the addiction clinic. This will be a presentation by Perrine ROUX in Marseille. And then we will we will finish by Jason Farrell, Bridging the Gap, Integrative Approach to Harm Reduction and Addiction Treatment. So that will be a presentation by Jason Farrell of Amsterdam, and he will be the third speaker. Right, without further ado, I'm going to give the floor to Martine. Okay, I'm going to say a few words, very quick. I'm very pleased to be here, and I think that my friend Patrick is also happy to be the co-moderator of this session on harm reduction. We are going to talk about a number of aspects at grassroots levels. We're also going to discuss research. If I can say a few words to the organizers, when you have no users in the panel, when we have a session on harm reduction, is a bit of a shame. It would have been good, it would have been better if you had users as panel members in this harm reduction session. And in the future, it would be nice to have users, because my understanding of harm reduction involves users. And so I think it's a shame that none of them is represented here this morning. In the meantime, I'm happy to have people around me, people that I've known for many years, for many of them, and for reasons because she's far away, we are going to start by the speaker number 3 on the program. So she has a registered, a recorded presentation, Sandra Krummer. So Sandra Krummer is connected, but we're going to listen to a recorded presentation. So without further ado, we are going to ask the technical team to give us the presentation of Sandra Krummer.
Thank the meeting organizers for inviting me to give this presentation, and you for your interest in hearing it. So let me share my screen. So what I'd like to talk to you about today is the process of developing medications for treating opioid use disorder, and to discuss how well the procedures match up in terms of preclinical to clinical laboratory studies and clinical treatment trials. All of the research that I'll be presenting today was supported by NIDA, and I just want to show you some of my disclosures. Opioid use disorder is prevalent worldwide, and it's particularly problematic in the United States. Unfortunately, opioid-related fatalities are still increasing. These are the most recent data from the CDC describing opioid-related overdose deaths by drug class, and most of it is being driven by fentanyl and its analogs, as you can see here. These are data that were recently published in the Journal of the American Medical Association. So in terms of overall deaths, the leading cause is due to heart disease, followed by cancer. And then in this past year, COVID-19 was the third leading cause of death. And after that is unintentional injuries. And these are, by and large, drug-related overdose deaths. And of these, the big driver, as I just showed you, is opioids. So I want to talk to you about developing medications for treating opioid use disorder, because this is one of the best approaches that we have now to protect people from overdose, both fatal and non-fatal. So we'll concentrate on maintenance therapy, and we'll describe to you the preclinical and clinical models that are used to develop these medications. And I'll start first with the approved medications, and these are all opioids that are that have been approved, and then take you through an example of a non-opioid medication. So just to tell you what I'm going to tell you, there's good translation from preclinical to clinical studies to treatment for the opioid medications for the most part. And there's not as good translation for non-opioid medications. And so the question is, why not? So in the US, there are three main medication maintenance approaches. One is, the first one that was approved was methadone in 1972. This is a full mu opioid agonist, followed by the approval of naltrexone. It's an opioid antagonist. And then more recently, buprenorphine, which is a partial agonist. So some of the preclinical and clinical laboratory models for maintenance medications include the following. So in the preclinical area, there's the conditioned place preference. There's an intracranial self-stimulation procedure. The gold standard tends to be the intravenous drug self-administration, and then drug discrimination is also used. In clinical settings, subjective effects questionnaires are most commonly used. The drug discrimination procedure is also used on occasion, and then self-administration using various types of procedures. So with regard to the preclinical models, I want to take you through briefly what each of them are. So this is the conditioned place preference model. It just basically measures the ability of stimuli associated with drug to influence behavior. So the animal is injected with drug and placed in one chamber, and then on a separate session, injected with saline, for example, and placed in the other chamber. And then on a test day, after repeated pairings of that, they are placed in the chamber where they can freely move from one to the other. And the amount of time that they spend in the drug-associated chamber is viewed as the as the preferred side. Intracranial self-stimulation involves placing an electrode into the medial forebrain bundle and measuring the ability of, or the interest of the animal in pressing a lever to receive stimulation in that area of the brain. And if a drug that is of abuse is given, then it shifts this curve to the left or the right, and it measures the ability of the drug to modify responding for the stimulus, that electrical impulse into that area of the brain that is believed to be associated with reward. The IV self-administration model is one where an intravenous catheter is placed into the animal. There's an infusion pump that pumps drug into the animal if they press a lever. So this is the model that most directly measures drug taking behavior in people, and because it measures the ability of the drug itself to influence behavior. And then finally, the drug discrimination procedure is one where the animal is injected with drug and trained to respond on one lever for a food reward. And then on another day, they get an injection of saline and they respond on the other lever. And eventually they learn to discriminate the drug from the saline. And on a test day, if a novel drug is administered, they are allowed to respond on either lever to be reinforced with food. And this measures the ability of the test drug to elicit responding on a lever that was previously associated with a training drug. So this measures the similarity between the test drug and the training drug. Clinically, the procedures involve subjective effects questionnaires, drug discrimination, and self-administration. So subjective effects include questions like the following: I like the drug, and this is often given on a bipolar scale, anchored on one side with dislike very much and on the other side with like very much. And the person is just simply told to make a mark along the line, how much they like or dislike the drug. We also ask a bunch of other questions like I feel high, I feel a good effect, bad effect, etc. So the self-administration procedure, there are a variety of ways of doing this, but I'll describe to you the way that we do it in my lab. So we use a drug versus money choice procedure where, participants are given a sample dose of drug and told that they would be also working for money, in this case, $20. And then during a separate session, they're allowed to choose to work for either the drug or the money, and by making clicks on a computer mouse. So we measure the amount of responding that's elicited by the drug and preference for the drug over money. So in this procedure, if the person, select drug option 7 times and the money option 3 times, and they had received 50 milligrams of drug on a previous sample session, then they would have earned 35 milligrams. And if they chose the drug option 3 times, then they would get $6. So each time the option is chosen, the number of responses required to obtain that fraction of the drug increases substantially. So here, the highest ratio value that they complete was would have been 1,600, and then for a drug, and then 200 for money. So in this procedure, the participant would have received 35 milligrams of drug and $6. And at the end of the session, the money goes into their bank, the drug goes into their arm, and they experience the drug effect. So let's go backwards from, with the approved medications. So I'll start with the treatment data, human lab data, and then the animal data, using the 3 approved medications that we have. So we know from, various studies, including this really nice one that Evgeny Krupitsky led, that naltrexone is effective in retaining participants in treatment. So over a 6-month period of time, about half of the participants were still in treatment if they received active naltrexone, and fewer people who received the placebo injection were retained in this study. Similar retention rates have been reported for methadone and buprenorphine. So this is 6 months of treatment, and with both of these medications, we have about half of the patients who are retained in treatment. So all 3 of these medications are effective. In the human laboratory, these are data from my lab a number of years ago. On the top, I'm showing you the breakpoint value, and on the bottom, I'm showing you subjective ratings of feeling a good drug effect. So under baseline conditions, each of these panels represents a week of testing. So this is baseline. They received the study medication here. And then we followed them for 6 weeks, giving different doses of heroin during the week. So under baseline conditions, heroin produced a dose-related increase in both breakpoint value and subjective ratings of good drug effect. After the naltrexone was administered, it completely suppressed both self-administration and subjective ratings for up to 4 weeks. By week 5, the effects of the naltrexone had begun to wear off, and by week 6, it had pretty much returned to baseline levels for both of these effects. Buprenorphine also produced a reduction in heroin self-administration here, and on the bottom panel, I'm showing you subjective ratings of feeling high. So under baseline conditions, or under placebo maintenance conditions, there was a lot of heroin self-administration that was suppressed in a dose-related manner by buprenorphine. And the same is true of the subjective ratings. These were data that were collected by Eric Donnie in Sharon Walsh's lab, showing you that when participants were maintained on different doses of methadone, this is 50, 100, and 150 milligrams per day, heroin self-administration was suppressed in a dose-related manner, and so were subjective ratings of feeling the strength of the drug effect. So in the human lab, all of these effects were suppressed in a similar manner. So what about the animal lab? These were data collected by James Rowlett, where he had monkeys self-administering heroin, and with naltrexone, there was a large dose-related rightward shift in the dose-response curve for heroin in all 4 of the monkeys that were tested. So these data are consistent with the human lab data. With buprenorphine, again, these are data collected by Steve Migas. There was a dose-related rightward shift in the dose response curve. So with the highest dose of buprenorphine, he reported the largest shift to the right. In the same paper, he was also reporting on the effects of methadone. So these are different doses of methadone that were given. And for this medication, for some reason, there is no change in heroin self-administration. And this effect has been reported in several other studies. So it's not just some procedural error here. So it's not really clear why methadone doesn't show the same pattern of effects as you would expect. The methadone in rodents, for example, though, do show, the pattern of responses that you would expect. So not sure why it doesn't hold up for primates. So let's go in the other direction with non-opioid medications. And I'll use as an example, Larcasterian. We'll start with the animal data, move to the human lab, and then treatment. So this was a summary paper that was published a few years ago by Greg Collins, Lisa Girac, and Charles France. So 11 out of 12 preclinical studies showed a positive effect for Larcasterian across multiple species in rats and monkeys and drug classes. So cocaine, nicotine, ethanol, and opioids. So this was viewed as a very promising medication, and there was a lot of excitement around it. So the rationale was that Larcasterian affects serotonin neurotransmission, and it is involved in drug reward and cue reactivity via the mesolimbic dopamine system. Activation of 2C receptors excites GABA neurons, which inhibit dopamine neurons. Larcasterian, or Belviq, is approved or was approved as a 5-HT2C receptor agonist for treating obesity. And it dose-dependently decreased oxycodone, cocaine, and nicotine self-administration and cue reactivity in preclinical models. So these are some data from that Martine published in Catherine Cunningham's lab. This is the effect of Larcasterian on oxycodone self-administration when it was given intravenously. And you can see that there's a dose-related reduction in self-administration that was reversed by this selective 5-HT2C receptor antagonist, SB242084. So this appears to be mediated by serotonin 2C receptors. Larcasterian also dose-dependently suppressed oxycodone cue reactivity following extinction reinstatement. So we evaluated Larcasterian in my lab, partly based on these data that were collected in rats, and also because Larcasterian had been shown to dose-dependently increase smoking cessation and prevent the associated weight gain that typically occurs with smoking cessation. So at the time that we ran this study, the effects of Larcasterian in humans on behaviors associated with opioid use disorder were unknown. So Larcasterian, we tested it as a maintenance medication in the 7-week inpatient study. We detoxified heroin users during the first week after admission into the hospital and stabilized them on either Larcasterian, placebo, or active, so 10 milligrams twice daily. And then we started testing. So the first week of testing involved active oxycodone self-administration, and then the second week of testing involved, placebo oxycodone in an extinction relapse kind of procedure. Then during the 5th week, participants were stabilized on the other dose that they had not been initially randomized to, and then we repeated the testing pattern. So what we found was that oxycodone was self-administered more than placebo. So here's, the percentage of drug choices was around 70% for active oxycodone. And when placebo was available, it decreased substantially. Larcasterian, however, had no effect on ongoing self-administration. And it didn't really affect much of the subjective responses of oxycodone, except for an increase in visual analog scale ratings of wanting heroin. So it actually increased, craving for heroin. And this was a study that Francis Levin in our group published recently, where they examined Larcasterian as a potential treatment for inducting patients onto extended release naltrexone. And their conclusion in this study was that Larcasterian failed to improve outpatient induction onto naltrexone. So these data suggest that at least this dose of Larcasterian may not be effective in treating opioid use disorder. So overall, there seems to be pretty good translation from preclinical to clinical to treatment, for opioid medications. So for the most part, methadone seems to be an exception for some reason. And there's not very good translation for non-opioid medications. So the question is why? One, easy response might be that there are just species differences in the effects of these medications. Another reason is probably, more important in that there are dosing limitations in humans, i.e. side effects, so that we are not able to, push the dose as high as we can in preclinical models. Another factor is, not related to medication. It's related to compliance with taking the medication. So in clinical treatment trials, for example, if the side effects, for example, are uncomfortable, then patients just won't take the medication, and obviously then it won't work. There also may be problems with the models, like there may be some procedures that are used in both the human lab and the preclinical models that may not be capturing the clinical situation quite adequately. And then another factor that we have not really paid enough attention to, I don't think, is effect sizes. So sometimes we see in the human lab and the preclinical models some reduction in self-administration, for example, but the magnitude of the change is not clear, like how much we need to reduce subjective ratings of drug liking or drug self-administration in order to translate effectively into good clinical outcomes. So I think the things that we need to pay more attention to are, the side effects profiles in these preclinical models that we have, as well as the effect sizes. Compliance has been a chronic problem, and there have been many attempts actually to address this issue. And I think we need to continue to concentrate on these. So I would like to thank a bunch of people in my lab for helping collect a lot of these data. And I'd like to thank you for your attention.
Écoutez, je remercie la remarquable présentation de Sandra Commer.
Thank you, Sandra Commer, for this remarkable presentation. I think if some of you want to ask questions, I think you can do that later in the morning. We'll tell you when. We are chairing a session on harm reduction. Research is working on that. We do the field work and you do the research. And I thank Perrine in advance. She's a researcher. Sorry, I did not.
So if there are questions concerning the presentation, you can ask them now because our colleague Sandra is connected. Bon, je répète en français. Vous pouvez poser des questions sur la présentation de notre.
You can ask a question on the presentation of Sandra Comer. She's now connected and she can answer. Are there any questions in the audience? It's very early for her, but it's still kind of early for us, and all the participants haven't arrived yet. That's why maybe it will come. So we can move on to the next presentation by Perrine ROUX, is INSERM researcher in Marseille. She's my neighbor, my friend. She's going to talk to us about. You have the floor. Tell us what you're going to talk to us about. Thank you, Béatrice. So we're going to talk about harm reduction. I would like to thank ATHS, Jean-Pierre Arcais, for inviting me, and especially for making it possible to meet Sandra. I met her during an ITHS 10 years ago, and after that I spent 2 years in New York as a postdoc at Columbia University. So thank you, Jean-Pierre, for this meeting. I'm going to talk about some of our work in my team, the CS team, and some work from other teams which showed how harm reduction can be beneficial for addiction clinics. First, I would like to honor 2 researchers who inspired my work. First of all, Sandrine Musso. She's an anthropologist. She invited me in 2020 to present some of her work during a meeting about which proposed different perspectives between anthropology and public health. She finally taught me how to have a different look on my research focus, to have a different perspective on drugs and addictions. She wrote how health anthropology is useful. She wrote a book to show that with other disciplines than epidemiology, we can give some answers and improve knowledge. I also would like to honor Mary Jean Creek. You did it already. She inspired my work because methadone is part of my research focus. Mary Jane Creek, very early in the 70s, she published and showed that methadone was well tolerated by the patients. She published her articles in the 70s. First of all, many of you know what is harm reduction, but I think it's important to tell you about the major principles of risk reduction. It's a strategy to reduce the negative consequences related to the use of drug, and with all uses, experimental, recreative, or in a treatment. This approach is both holistic. It takes the whole person. It's pragmatic. It has not only health objectives, but social and legal objectives. It's a community approach where the people are involved in their choices. It promotes social changes, and it's part of a set of principles which consists in respecting the rights of the users to be you don't judge, you encourage the responsibility of the users. There's also an outreach aspect, and involving, empowering the users in the harm reduction project. It's also a whole set of services, not only principles, and the two pillars of this approach are needle exchange programs and opioid substitution treatments. Many tools are being developed, consumption centers, reinsertion programs, and housing programs. This is part of the tools for harm reduction, up to PrEP for HIV. The states have used the method at a very early stage. In France, we used the Euprenorphine substitution in 96. For those who don't know the background, this treatment was prescribed for pain relief. And during the HIV outbreak among people who injected drugs, there was a non-official response who were called dealers in white coat, and they proposed this painkiller as a substitution treatment. And then it finally became an official response in 96 with access to methadone and buprenorphine, which became Subutex, which you all know in the tablet form. These substitution treatment are harm reduction tools. And in France, we have very interesting data showing that as the patients had access to that treatment, there was a reduction in injection practices among the users. At the same time, when these treatments became accessible, one of the major elements for health, public health, was a drastic reduction in overdoses. So this is some of our work showing that the treatments were also useful in the HIV care, because in a cohort, Manif 2000, of HIV infected patients, that substitution treatment had a positive impact on the observance with enteroretrovirals. We not only show that access to substitution treatment, methadone or buprenorphine, and the stopping injection, it was the same observance as people who did not consume. But even if the users continued injection, the observance was improving. With more objective criteria, the fact that you remain in a substitution treatment, you can reach a non-detectable viral load. If the substitution treatment are harm reduction tools, they are also associated to risk-taking. Some patients using Subutex inject their treatment. In a survey in the year 2000, the Subazur study in substituted patients, as after stabilization for 3 months with Subutex, 12% injected the treatment in the last month. An Australian study showed that 28% of the patients taking buprenorphine declared that they injected their treatment. And the Intracranial survey said that 35% of the carried users injected the treatment. There are many consequences when you inject the tablets. Of course, you know the risk of HCV and HIV, and the skin complications with endocarditis. Also stigmatization and the legal risk for the users, because they have they need diversion practices to obtain the medicine. In my practice as a pharmacist, this is a prescription of false, a counterfeit prescription for Subutex. So people are going to implement practices to have access to the treatment. So the question is the patient a failure or is the treatment a failure? So I have some answers. Through the Subazur survey, we were able to show what were the factors associated to the diversion of the treatment. So the factors associated to the injection of buprenorphine is the fact that the dosing is inadequate. Also, we explored the sniffing issue because buprenorphine is also sniffed by the patients. And the patients who think perceive the treatment as inadequate have a greater risk to sniff the treatment. Risk-taking in substitution. I'm asking that question. We don't have much data in the literature. The impact of substitution in the increase of consumption of other products. If you move from heroin to methadone, so maybe this should be looked into. There are some therapeutic responses. Suboxone was deployed in the United States. It's a buprenorphine combined to an opiate receptor antagonist, naloxone, to limit diversion by the patients. There was a study in Malaysia where Subutex was replaced by Suboxone. What the results of the study show that there is a reduction in the buprenorphine injection, but if you look more into the patient practices, the socio-anthropological studies with this public show that the patients cut the tablets and inject Suboxone more frequently. So it increases the risk, especially in countries where HIV prevalence is very high. And they associate Suboxone with heroin benzos to obtain the expected effect. And we also saw an increase of users injecting heroin in these populations. Another therapeutic answer to these injection practices was medical heroin by IV. Many clinical studies show the efficiency of this treatment. A few countries offer this treatment currently, and the access conditions are restrictive with a daily systematic supervision. So in this context, I participated in a study on the making available an injectable treatment in France, and I proposed to launch a survey with Ed and Sud with 557 people who injected opioids, and we were looking into the acceptability for an IV buprenorphine. The data, the results of this survey show a high acceptability. 83% of the persons said they were interested by the treatment, and especially those who had skin complications and who had less experience of overdoses. This accessibility decreased among youth, and it was less acceptable. Especially for the youth and people who were inserted in the community. And when they looked at acceptability in the buprenorphine injecting people, of course, it's more acceptable. But what's interesting is that those who did not receive buprenorphine were more interested by that treatment. It means that an injectable treatment could attract more people toward people who are not taken care of. We have also other therapeutic responses, not for people who inject, but they're interesting for more stabilized patients. There is a long-acting Euprenorphine. You've heard of it in the previous sessions. It's interesting for stabilized patients to reduce the constraints related to a daily take. But I also looked at the literature. It's a very recent treatment. There was a study in a Syrian exchange program in the States. It shows that the patients that are followed in harm reduction centers, they prefer tablets over long-acting. This is a preliminary study to be confirmed by a further survey. So it's important to widen the options there, and we have to take into account the choice and the preferences of the patients. There are several questions. First, is the treatment a priority for the person? What is the dosage? What is the dosage form most appropriate for the patient, long-acting or IV? Which molecule? The patient can choose from buprenorphine to morphinic products. And what happens when you, at the end of the substitution program? This is not explored in the scientific literature, but we should also focus on that. Next to the therapeutic options, I just wanted to talk about the framework and the place where these people are being cared for. This is work from a study I did in New York at Columbia University. Sharon, I did that with Sharon, and I evaluated in their low threshold program for vulnerable people. And this low threshold program is very innovative and unique. At the time, there were very few such programs in the States. So we showed a very good retention in treatment, at least for the public which has no access to care, and they are maintained in care in spite of very difficult living conditions. Another question is, of course, we know access in specialized centers, in hospitals, but what about general practitioners? This is part of the work we did in the studies with Patricia Carreri, a randomized study showing that initiating methadone with a GP is like initiating methadone in the specialized centers. Another result of that study is that the persons randomized in general practice refuse the study less. So this is one of the main results of this study. This study was mentioned recently, showing that this is very efficient and acceptable by the patients. I don't have scientific data on microstructures, but an intermediate model being developed in France is very interesting, and it consists in taking care of patients through professionals interested in that type of public. Another quick question, it's you have to take into account the perception by the patient. This is the work of a colleague from New York, a sociologist. He did a study with people taking methadone, and it shows that the perception of the patients are very critical towards the restrictive policy of methadone access, where the patient asks to take the treatment every day on a regular basis. And they described methadone as liquid handcuffs. And it shows how maybe we could improve how we deal with this public. there was also a biological study showing a very good concordance between what the patient tells in terms of perception and the methadone dosage. So we can trust the patient in the care he receives. I'm almost finished.
Ça bloque. Tant pis. Juste, bon, pour finir.
In conclusion, a pragmatic approach where we're going to take into account the environment, the preferences of the patient. So it's what harm reduction is teaching us, especially combining the harm reduction tools, even for people being treated, substitution treatment associated to tools, to sterile equipment, to a whole set of services, and take into account the social environment on these vulnerable people to improve the treatment. Thank you.
Thank you very much, Perrine. Thank you very much, Perrine. So we had two presentations which are rather well coordinated, all the more so as Perrine worked with the previous speaker as well. Maybe we are going to dedicate a Q&A time to those two first presentations, and then we'll move to the next presentation because we have plenty of time, right? So if you don't mind, Jason, we are going to take questions first. A comment first from Patrick. I find the study by Perrine, and I find it quite remarkable. And it does pose the question of translation between clinic and research. As a quick reminder, I would like to remind you the early days of harm reduction in France. I'm the co-chair of that session with Béatrice STAMBUL, and both of us are quite familiar with the missions of an NGO named Mission Médecins du Monde, and they self-proclaimed themselves as the Association for Harm Reduction. And they had an alliance back in the days with AIDS, ACED, so user association, and Médecins du Monde, Doctors of the World, and also the Mutualité Française, French Mutuality. So they have a rather large network, and they have self-assigned an objective of public health, harm reduction, and then they imposed that to public power. This is a momentum which I call the humanitarian dynamic. So you find a problem, or you see a problem, you find solutions, and you ask public power to tackle this problem and change things. So back in the days, we wanted to change laws through depenalization. This was not possible, so we started changing behaviors. We're talking here about the years 1994, 1995. We started with a network called Marseille. This had to do with reaching out to individuals who were completely excluded from the conventional care pathway. They had an HIV prevalence of 40 to 50%, very high back then. And now when we look at what's happening in care roads, in those centers, it is quite remarkable. Now, I heard in the last few days of this conference that the momentum is sort of losing traction. Harm reduction is like a fight. It's really difficult. You have to reach out to difficult populations. And if we want to apply all the items of harm reduction And Jason Farrell is going to talk about the different elements of harm reduction. And he knows, and we know, that it's very difficult. Now, what strikes me in this presentation, in the presentation of Sandra Kromer, she talks about preclinical models, and she talks about how we can reduce dependency, and she shows how this target, and she shows how many fatalities there are because of overdoses. She's talking about 70,000 fatalities per year, which is a huge problem. So what's the impact of health reduction on that? It increased from 5,000 to 70,000 in 10 years, if I got that right. So that's a real issue. That's a real issue. Now, this is a real issue. And in Europe, we do not have, except in Scotland, we do not have comparable figures. And that's probably again this question of harm reduction, because you need to have a holistic approach. And it's true that if you do not have this holistic approach, it doesn't work as well. And I think we'll have a nice conversation with Jason later on this topic. Now, to pick up on what you just said, Sandra presented her results on drugs, on substitution as well. Those are the different harm reduction tools, but Sandra also takes part to a number of programs on training to naloxone administration with in mind the American context. So she conducted very interesting projects on that, on syringe exchange as well, training to naloxone administration. And those are also interventions that we should promote in the American context. Are there questions in the room from the public? Well, thank you, Perrine, we can't hear. Yeah, we can hardly hear you. Well, thank you, Perrine, for all. I would be more concrete. I'm going to come to my question. I have many remarks, but I have a bit of a criticism about Suboxone. You mentioned the experience of the experiment in Malaysia. You know the work of Altis, if I'm sure. They are experts in addictology. And I think, okay, so you need to think about what happened in Malaysia, in Singapore as well. In Singapore, Subutex, buprenorphine is forbidden. And in Malaysia, they jumpsuit and they followed in the footsteps of that country. And so what was observed in those countries, so Malaysia, so there was an increase of dose. So I think you're one of the French authors who wrote the most on this subject. And I would like to know about buprenorphine. I'm sorry, the speaker keeps backtracking. It's very hard to follow. So we say that, let's come back to buprenorphine. You demonstrated that the underdosage of buprenorphine is also a factor of increase of consumption. In Malaysia, do you know which average dose was injected? I think they went from 1.8 to 2.5 milligram per day sublingual. And we know that the efficient dose is between 16 and 24 milligrams. So all this to say that, you cite Malaysia, but you do not cite the question of low dosage, too low dosage. And you are aware of that. You are the one in France who demonstrated that when the dose is too low, then of course you do not have the effect that is expected. So it's a non-relevant dose of buprenorphine, and there are a number of side effects. So I thought it was a shame that you didn't mention that for Malaysia. Okay, so yes, dosage or the molecule as well has an impact. If the user doesn't receive the right dose, or if the molecule doesn't agree with her or him, of course there will be more improper use, obviously. Now, this study in Malaysia, I did cite that study because it does shed some light on some practices with Suboxone, and sometimes we forget about those. I talked with users in that study, and they confirmed that those practices were observed, and they did not understand why. But again, you break down or you fraction that, they no longer have the effect of naloxone, and then they inject on many occasions to get the research effect. Our study in Vietnam was published, and we demonstrated exactly the opposite in Vietnam. And I will give it to you so that you can read it. Okay. Okay, I'll have a word about this later, says the moderator. Do we have other questions from the public for Perrine? I see a few show of hands. Mark and someone else at the back. Well, thank you very much for those two first presentations. Now I see a bridge between your presentations on on models. Maybe in her presentation, Sandra Comer shows that there's a sort of gap between what is anticipated from preclinical studies and what we see. And we see that in your presentation, Perrine, as well, a gap, an offset between the measures that are taken and the results that you have in effect. So maybe we should step back and have a closer look at the models, be they the animal models or the human lab models, and compare that with harm reduction. Maybe go into more details, finer granularity, the question of dose. Jean-Pierre Deloued was mentioning that, the importance of dose, and maybe have more qualitative study to see also the difference between real-world data and clinical data and preclinical data as well, and maybe to try and bridge that gap, bridge that question of translation. Well, again, we do not want to talk too much about that, because I think this is what the next speaker will be talking about. So, and we want to conclude at 10:45 as well. So we do not want to spend too much time on questions. Thank you very much for this presentation. My name is Damien Carbonat. I'm an addictologist near Paris. We had a number of combined forms of buprenorphine, and we saw that there was an increase from 16 to 24 milligrams of the injected dose. There was a change in paradigm. And so in some cases, we are at a loss at what to do with those subjects that are addicted to those substitution treatments. And I would like to know how you manage those subjects. Well, maybe I'm going to give the floor to addictologist. I'm not a clinician myself. Béatrice, is there something you could say about those? Oh, Béatrice, you didn't listen. So there's a clinical question on how you manage those patients who are addicted to injections when they inject strong doses of buprenorphine. Well, they're addicted to injections. For some of them, they had an underdose, so increasing from 16 to 24 solved a number of those issues. They were using an extra injection because they were not properly managed with 60 milligrams. So increasing to 24 milligrams did help, but others are addicted to that. Well, maybe I do not have the right answer. You need to have a look at the person as a whole, and you need to work with those patients. Those injections of substitution, sometimes they have a hard time talking about it because they're ashamed of what we're doing with that. Now, we working at grassroots levels at harm reduction, and we can see that all tools can be used in the intended way, but also in a different way. And sometimes those tools are perceived as a way to control those users. You know, some of these users say that they feel that those substitution treatments are liquid handcuffs. So after those many years in harm reduction, I see that unfortunately the health authorities are still quite reluctant at making the right decisions. And I think that in harm reduction, and I don't want to reiterate what I already said, I think you should have, of course, a one-to-one and a personalized approach to each of your patients with such an issue. But again, this requires a very comprehensive approach, and sometimes you need to accept things that they say or that they perceive. I'm sorry, I still have a question, says someone in the public. Hello. I would like to know what are the results on your study on injectable buprenorphine. So you have a study on injectable buprenorphine, right? Good questions. So my results in a nutshell. I was asked by industry leaders to conduct a study. It was Etiform. Etiform was a sponsor of this intravenous buprenorphine project. For the time being, the study is still in the works. It has not been conducted because apparently it is difficult to have a stable product in a liquid form. So for the time being, it's still a project, and we have not conducted that study. Hopefully one day. But the objective of that is to try and relieve the taboo connected to injection. And I'm not talking as a researcher here, but we want the users, the patients, to talk about a treatment. And if it's a treatment which is used as an injectable form, then you do not have a taboo to inject something which is not meant to be injected in the first place. Okay, we're going to conclude that Q&A session here. But Professor Kommer is connected here. And so maybe we can take advantage of her being up at such an early hour to ask questions.
Are there any questions for Professor Kommer from Philadelphia? Yes.
Good morning, everyone. Well, good morning.
Good morning. It's very early for you. We are sorry.
Yeah, don't worry.
So,
Bonjour. Oui, une question pour Sandra
Hello.
Kommer.
So a question for you on your models.
do you have the translation or not? Do you hear the translation?
Yeah, can you hear the translation?
Yes, I heard. I didn't hear the question.
No, because the question was not asked. They wanted to check that you could hear the translation before they ask a question.
Yes, I can hear.
A question, and you heard the debates about the issue. So one of the questions is maybe our models.
So they ask a question in English directly, right? On the models.
We need to go further to understand the different gaps. And one of the things that is reported by patients is, was quoted by Perrine, is some patients report that experiencing methadone, or you have the same, I think, with buprenorphine, is like having liquid handcuffs, feeling like a prison, in a kind of prison. And then in other qualitative studies, you have the opposite that is reported. And you have patients that say, wow, being on methadone is being freed. I get my freedom back. And you have that also with buprenorphine. So I think the question, how can we reconciliate, and we need to make it short, sorry, how can we reconciliate how with the same medication, individuals will experience totally opposite experiences, one of being handcuffed and the other being unhandcuffed.
Thank you, Mark. That's a really interesting question, and I was not familiar with that paper. I took a screenshot because I want to go back and read it about the patient who said that they, experienced methadone as a liquid handcuff. I haven't heard that before, and I wonder actually if the statement is related to the difficult procedures that are surrounding obtaining methadone. And, so that's one component. So I think we have to dig a little bit deeper into the reason why that feeling was expressed. The other part has to do with just generally the feeling that being on an opioid is constricting because, they have to take it repeatedly. And, being on something like methadone will just continue that kind of experience that somebody has, and that they would prefer to be off of it completely. So, I've started doing some qualitative research as well. And I think it's really valuable to provide a real world, perspective from the users. I really enjoy doing that. But I think trying to interpret some of these data is a little bit complicated too. I'm a behaviorist, and so I like to, see how the behavior changes, because if we're concerned about continuing use, and if we can make it less risky for patients to, experience these drugs or to stop taking it, I think we need to focus on the behavior as well as the verbal reports. So, these models that we have are really only valuable to the extent that it predicts, behavior and some of these outcomes that we have. So yes, in general, I completely agree that we need to, dive a lot deeper and to try to make the models match what's happening.
Thank you very much. Are there any other questions? D'autres questions? Non. Donc, thank you very much. We have to go on with the program. Thank you. Donc, je vous présente maintenant.
Now, we are going to introduce Jason Farrell. He's a pioneer in the development of risk reduction. I've known him for 30 years. We were co-founders of Harm Reduction International, and he created one-stop shop care point. He's been in this field for more than 30 years, worked in the United States, is currently in the Netherlands, where he created the Positive Health Project. And he transferred that again in the Netherlands. He works in the Netherlands since 2009. I give him the floor.
Good morning, and thank you for coming. I want to thank Jean-Pierre, Cecilia, and the whole team for inviting me. I feel like we're part of a family here with my colleagues, and I will speak in the microphone. Yes, okay. I will speak slowly because we have translators, and I know English is not a language many of you will speak on a daily basis. But speaking Dutch is not so easy also. So, okay, so brief introduction. We will talk about how using harm reduction interventions can be effective in helping people who can no longer manage their drug use start treatment and minimize the risk of HIV, hepatitis, and STI infections. When we put drug use in the context of a risk behavior, it opens up opportunities to discuss the specific risks related to their use and the benefits to minimize and eliminate. So in a nutshell, when people ask us, well, what do you do at Choice Support Center? Well, we help people who can no longer manage their drug use. Many who come to us do not feel they require inpatient or outpatient treatment. What they want is to make changes, but need some guidance. We help them take the first steps towards establishing a pragmatic prevention plan, a prevention care plan with realistic, actionable goals and objectives. Like Ms. Comer said, it's all about behavior. Our mission is to connect people with appropriate addiction, mental health, medical treatment by providing advocacy, support services, and assistance needed to improve treatment, outcomes, and retention. The concept in care and service is based upon research and current surveillance data designed to fill gaps in the continuum of care to address the trends in drug use risk behaviors and improve treatment outcomes and retention. We see poor retention and treatment, long intake waiting periods, and very few comprehensive services for the LGBT community with addiction problems. We focus on behavior change utilizing evidence-based behavior interventions. Our clients participate in behavior change interventions to minimize and eliminate the drug use and the risk behaviors associated with that drug use. The interventions are treatment readiness interventions, which we actually prepare people before they start treatment to improve their retention and outcomes. And this was developed in my medical center in New York when we started. Well, first of all, I opened the first harm reduction program in the United States with an on-site medical center. And when we were providing HIV testing, treatment adherence is very important. So when you work with drug users who need to take medication for the rest of their life, adherence was very important. So we developed treatment adherence interventions, and these interventions can be applied for any kind of treatment. We also use social network interventions, which my friend and colleague in the US, Carl Latkin, is one of the people who helped develop these models, where you change the people's social network to improve and integrate and support the change of new behavior, which is very important. So our services include low threshold online registration through our website. We do an intake and a triage. We provide individual and group interventions. We provide groups, particularly around chemsex and treatment readiness. We offer access to testing. We're right across the street from the health department, and we distribute self-tests so people can go home and test themselves or test themselves in the office. We offer yoga, meditation, and we have direct referrals to all the treatment facilities throughout the Netherlands, including addiction and mental health. We see predominantly gay men and people in the LGBT community with drug and sex addiction. Despite Amsterdam being a very diverse city, there is a gap in drug services focusing on the needs of gay men and the LGBT community. Recently, more LGBT migrants are struggling with drug use upon arriving to Amsterdam. Some of our numbers. Now, take into consideration, we just opened in 2020. The week COVID hit was the day I signed the lease on my office. So you can imagine the panic. Despite that, and being a new organization trying to develop trust within the community, we were able to see about 36 clients. As you can see, we're surprisingly seeing a significant number of people over 50, and our referral source is primarily through word of mouth, friends. 61% of our clients successfully reached their goals to change their drug use, and 100% changed their sexual risk reduction goals. Now, when we talk about goals, we need to talk about harm reduction and addiction care. As we talked about early, historically, harm reduction has been at opposite ends with addiction care, when in fact, they're very much the same. The context of harm reduction, we help people self-define personal recovery towards well-being without the use of drugs or risk behaviors associated with the drug use. The culture of harm reduction programs support the safer use of drugs among those who are not ready, willing, or capable to stop. Now, the culture of supporting drug use safely, having fun, manage your use, sends conflicting messages to those who want to minimize or just stop. Within harm reduction programs, people become empowered, some more motivated than others, who want to make changes, but reach the plateau of care available. Now, in European harm reduction programs, very different than the American ones, we don't see behavior interventions on an individual basis to help people pragmatically work towards eliminating risk behaviors. It's what we do. So what happens is when you work with people who have been going to a harm reduction, there's betrayal and fear. When confronted with leaving the safety of a harm reduction program, you can no longer live up to the culture, right, of an organization that's been there to help you. You seem like you're going against that. An organization that has been really helpful for you. Feelings of betrayal, fear, failure, inadequacy, and anxiety come to mind. Going to rehab, a 12-step meeting, or therapy are reasonable options, but all of it require commitment or setting goals and achieving outcomes that have been unattainable for many. They're very unrealistic for many people. So the bar is set way too high. So what happens when you want to make change and you're not ready to go to inpatient addiction, but the setting in which you're at now is not really doing it for you? So there are low threshold solutions. What happens is when this group of people who is motivated to change their drug use, they're not supported by the harm reduction program due to the culture and their social network going to that program all the time because they want to do something a little bit different. They're better off connecting with others who are like them, more motivated to make drug use and lifestyle changes in a different setting that has a culture supportive of change and provides that structured support. At Choices Support Center, we offer that. We first assess that the person is in need of treatment, detox, mental health care, or other medical care. Once we figure that out, and they're ready to really participate in a pragmatic process, we start that change by preventing a prevention plan. And this is based on prevention case management, something I developed at the CDC in the US, which has been very effective. So by making choices, together the psychologist and the client identify the barriers to personal goals and well-being. In many cases, it tends to be the drug use and sexual behaviors. But upon identifying the fact that drug use and the lifestyle centered around the use is creating these problems, that is what becomes the goal to minimize or eliminate to successfully reach desired goals. When the plan is negotiated between the client and the psychologist, that becomes the roadmap. Together, they work towards reaching each goal by establishing actionable behavior change tasks that will be done with an agreed upon time period. And if it doesn't work out, you go back. But the goal always stays the same. It's the steps towards that goal that could be negotiated. Our groups connect the client with others who are working on a plan and may have similar goals. The group becomes a new social network supporting, integrating, and maintaining these new behaviors and lifestyle. So prevention care plans are pragmatic steps to achieve realistic and achievable goals. For many, drug cessation is really a goal, but although sometimes the identified risk associated with their drug use will take precedence, hierarchy of risks, right? Harm reduction. So this may include just reducing the number of unknown sexual partners to a limited number of known partners, or replacing drug use with increased intimacy, maybe talking to the person before having sex with them. The negotiating process of creating the personal plan provides the first opportunity for many to explore how the drug use and their sexual behaviors may have affected various aspects of their life, whereby creating barriers to personal goals, employment, how it affects their vanity, performance, as well as creating relationship problems, health problems, and of course, infections. Because we're talking about a group that's involved in chemsex, I don't know if many of you know about chemsex, but it is a growing issue within the gay community throughout Europe. Many are ambivalent about making changes to their drug use or how to make change. These are some of our outcomes. In a country where managed drug use has been normalized and accepted, those who can no longer manage their drug use feel inadequate and stigmatized within their social network. So we found that many need the psychological support to get them to their next phase in behavior change towards recovery, their own self-defined recovery. Clients tell us the reason that they come to us is because they haven't found a place that feels accessible. We're not too medicalized or mainstream, thank God. And by helping our clients connect the dots, offering guidance towards creating a mutually agreed upon plan, we minimize the anxiety to make changes and better choices. I want to thank my colleagues, and I want to thank all of you for your patience and understanding and your attention. Thank you so much.
Thank you. Thank you, Jason. I speak in French, so you put that your...
Yeah.
Je vais parler en français.
Yeah, I'm going to speak French, and you're going to have my translation. So thank you, Jason. We've known each other for many years, as Patrick said. That was an excellent presentation, which is really in the spirit of what should be harm reduction. Non-judgmental, as we say in French, full of respect of users, and which helps step by step to help the individual without projecting our own priorities, our own preconceptions, and with attainable goal. And it restores self-esteem with many steps. And so I find that this program is quite adapted potentially to Amsterdam, but I think we can be inspired by this model, because it's really with that model, with that spirit, that harm reduction can be a success. And by integrating people that, if not, are not included in other programs with a higher threshold, and you know, people that at the end of the day are already faring rather well, so the others are excluded. Are there questions from the public for Jason? Oh, Mark. Thank you. Well, all this, of course, is very passionate, and it's creating quite a turmoil in my head. Thank you very much, Jason, for this presentation of your program. And I see that you are quite concerned. Can you hear? Yeah, well, of course you can hear. I see that you have a quite integrated approach, a comprehensive approach, and you're taking into account the needs of those people wherever they are, and you're using all the tools without preconceptions. And I think that's what describes your program, an integrated program with risk reduction and treatment. There's translation. There's translation. Okay.
Do you hear the translation now?
Can you still?
Okay.
Well, I don't know why. Because I'm talking.
Now I hear the woman now, but she didn't translate.
I did translate.
So I didn't hear it.
Okay, that's all right.
Briefly, what I understood from what you said is that, and I was thanking you for the integrated approach.
Thank you.
Taking the person as the person comes and trying to adjust different tools from basic harm reduction to full treatment of addiction, right?
Yeah, yeah. The continuum.
Right, a continuum. So I would say, so sometimes we speak a lot, and I think that that's a problem, more of a solution about au seuil, pas seuil en anglais, comment on dit déjà? Thresholds.
High and low thresholds.
Low thresholds. So would you say your system is a low threshold?
Yeah.
Or would you say it's a no threshold? Because I never understand, why should there be any threshold at all?
You're right. Well,
and just before another comment so that you can.
Go ahead.
I think also one of the problems we have is about these thresholds. And another issue is about what actually is harm reduction. It was just said that as a kind of summing up of what was said about harm reduction. So it was said in French, but is it really true that harm reduction is taking people where they are? Yes, where they are. Comment tu as dit déjà?
Je disais que la réduction des risques prend les
personnes. I was saying that harm reduction takes the people where they are. So there are proposals that are adapted to the perception we have of a subject without preconceptions, without judgment, and we're not trying to project what we want for them. We do not decide for them what we want them to do. This is what I said. So we're coming to my question. So is there an alternative to that? So if we have too large of a definition of harm reduction, maybe we're not hitting the target. Because can a user say, well, I do, or can someone say, well, I do not want to do that. I do not want to take the person where they are. I want to impose something. I want to do what I want. And if they don't agree, they should just bugger off. So, you know, that's a bit of my thinking. And so if we want to have a more integrated approach, maybe we need to have other definitions. Because what's the alternative if, you know, not everybody agrees with your approach? Well, I'm going to answer that quickly. You know, with anonymous narcotics with 12 steps, I think is completely the opposite to harm reduction, because you already have a program, you need to accept or you can be part of that program. So I'm not saying that it is useless. It may be useful in the framework of a form of conditioning, but from a philosophical point of view, I think it's the opposite to harm reduction. But then again, we all know colleagues who work in addictology and decided to work in addictology because it's something that is well seen in our country, and they prescribe methadone not with the right intention or intent. And I'm not going again to try and point fingers at some, but that's an interesting question.
What I also find interesting is the different approaches to harm reduction. So when I first arrived in the Netherlands, I was working with the European Harm Reduction Network, doing capacity building and harm reduction programs throughout Europe. And visiting all these programs, what I've noticed was very different than establishing harm reduction programs in the US. Was the US model was very focused on behavior change, minimizing risk behaviors. You have a captured audience coming every day. What are you doing with these people who come to your office every day? The intake and triage are the right questions being asked among people registering for your program. So if someone's coming to my organization and they're using drugs for maybe a year or so, I would ask them, have they ever considered other options? Rather than just say, hey, that's great. Here's all the equipment you need and use safely. Right. But there are choices that people can make. If that person is totally adamant about using drugs and they don't want a discussion around other options around treatment, fine. Here's the equipment, here's the education, here's the information that you need. Whenever you want to talk, we could talk about it. And that's the end of it. I don't revisit that unless they approach me again and want to talk about that. So also additionally is the behavior intervention. It's all about changing behaviors, harm reduction. It doesn't happen through osmosis or just by coming to an organization, getting coffee and sandwiches. What are we doing with people in harm reduction programs? How are we helping guide them and facilitate behavior change, right? Teaching people how to inject safely has become very important around hepatitis infection. And we learned many organizations are not really adequately prepared or staff knowledgeable how to teach safe injection to prevent infection and reinfection. So that became a big issue. So as we learn and move forward, these are things that we could start implementing to enhance the continuum of care within harm reduction programs. But what we know now is there is a concern about the lack of interest and support for harm reduction. So we've gotten to a certain point, and now we really need to keep pushing forward to enhance that continuum. And the fight must go on. And we need to continue that, because the model that I do and that's done otherwhere, offering buprenorphine to people in needle exchange programs, because who's going to go into withdrawal voluntarily to start? When you came to my program and you were in withdrawal, I would say, hey, listen, you want a pill or a needle? I can give you a pill now, and you can take a break for a day, come back tomorrow, and I can give you another one, because they come to us in withdrawal. Right? So you capture them in the moment. That's one model. So how can we look at all of these models and expand the continuum of care of these programs? But they need the infrastructure and the support and the money. And that's where the fight must continue. Yeah? So, any other questions?
Merci, Jason.
Well, thank you, Jason. Thank you, Jason, for that. Unfortunately, we do not have much time left. I would say that we have time for one extra question. I see one hand. Hello, France. Maybe one day we'll be able to merge the concept of XAPA and CARUD, very French concepts. Maybe we'll be able to prescribe Subutex and also have a prescription at the same time. And maybe we'll be able to do in France what the gentleman does in the Netherlands.
We have to explain that. In France, it's different facilities where you get your syringes and where you get your buprenorphine or methadone. So if we could have one facility which would be low threshold, and you could have either or, not either or, but both.
Exactly. Yeah.
That's what.
Yeah. That's what we did at my medical center in New York years ago.
Bien. Écoutez, je remercie d'abord notre intervenante des
Well, thank you to our American speaker who is now asleep, no longer asleep, and she stopped sleeping for us. So thank you so much.
The pleasure of being with us, and we're very happy with that. Et merci aux interventions.
Thank you as well to the other speakers, because they shared different lights on different sides of the same question. And I think we could demonstrate the general nature of harm reduction. So thank you very much to the organizers. We're going to have a break now, and we shall resume at 11. Thank you.